morning, everybody. I can see that numbers are still joining, but I think we have the vast majority of people coming online now. My name is Suzanne Costello. I'm the CEO of the Institute of Public Health, and on behalf of the Institute, I'd like to welcome you to today's seminar on arts and creativity in later life, implications for public health and older people. And may I extend a particular welcome to attendees from the arts community. It's lovely to have so many of you at this event this morning. The arts contribute so much to our well-being, physically, mentally, and emotionally. The WHO report of 2019 provided a comprehensive evidence base for something many of us experience and recognize in our own work and lives. To impact on population health, it is important that the benefits of arts and creativity are available to everybody, and that we understand exactly what those benefits are and how we can measure them, and what needs to be done to ensure that everyone can access them. Today's speakers will shed some light on these challenges. I'm delighted that Dr. Niels Fietsche is joining us from WHO, who set the scene for this work in their 2019 report on arts and health interventions. I'd like to congratulate my colleagues, Professor Roger Sullivan and Laura McQuaid, who have led this initiative for the IPH, and for their foresight in drawing on the expertise of Dr. Cornia Creeley and Professor Kieran O'Neill in economic evaluations. These are key to enabling interventions at scale. The value of arts and creativity in health and well-being is recognised in Healthy Ireland, Making Life Better and Sláintecare. I hope today's report will contribute to the achievement of some of the objectives set out in these strategies. And with that, I will hand over to my colleague Laura McQuaid for the first presentation for this morning's seminar. Thank you.
Good morning, everyone. I'm delighted to be able to share with you today our presentation on arts and creativity in later life, looking at its implications for health and well-being in older adults. Today, I'm going to discuss a little bit of the background to the study, look at the study aims, talk about the methodological process that we went through, look at the quality appraisal of studies, and provide a summary of those that we included. I'm also going to look at the impact of the arts on health outcomes and look at the considerations for research, policy, and practice. So just to look at the background, in Northern Ireland, our ageing population is growing, and one of the greatest successes of public health is that people are living longer than ever before. Over the last decade, the proportion of the population aged 85 and over in Northern Ireland has increased by 30% and has grown at a rate 5 times higher than the population as a whole. As Suzanne had mentioned there, the World Health Organization report in 2019 had said to us that arts and creative activities can be a way of alleviating or preventing the deterioration of health and can offer opportunities for social engagement and interactions with others. When we look at the slide here, we look at participation and attendance in the arts by age. A continuous household survey by NISRA in 2019 and 20 show the attendance and participation of older adults. As we can see, from the age of 35 onwards, participation in the arts declines with age, and specifically for those aged 65 and over seem to be less likely to participate. These figures are quite similar as well in Ireland, with about 25% of older adults participating in the arts. Previous research has really concentrated predominantly on the arts and creativity interventions, either in terms of therapy-based, with older adults with diagnosed health conditions or diseases, or just looking at one sole art form such as dance or music. There's been little empirical evidence which systematically reviews the evidence and examines the impact of participating in arts and creativity interventions, looking across the different art forms and identifying the impact for healthy adults and specifically across both physical and psychological health and well-being domains. So the aim of our study then was to look at a mixed method systematic review, and this was to develop a better understanding of the evidence that exists in relation to the role of arts and creativity programs for older people, and also to examine the effects of arts and creativity and how it impacts on older people's health and well-being. Our research questions looked at how does participation in arts and creativity impact on older adults' well-being? How does the evidence suggest that certain arts and creativity-based activities differ in their effectiveness than others in supporting better health outcomes? What does the evidence tell us in this field about collecting and different ways to measure and assess program design and benefits? And also, what does the evidence tell us about funding arts and creativity programs and whether this provides a return on investment? We took a systematic review process using PRISMA guidelines and went through all of the different stages in which to systematically review the evidence. Empirical studies that were published over a 5-year period were included, and 14 electronic databases were searched across a number of health and arts databases. We used a combination of mesh terms and key search terms, and also key concepts. We had a search of the Braille literature as well to make sure that we could include as much studies as possible. And we used the purling method for the references and citations from other similar reviews that have been conducted. So when we define arts and creativity, we used the Arts Act 2003 in Ireland, which states it's any creative or interpretive expression, whether traditional or contemporary, and in whatever form. Obviously, the arts and creativity definitions have been widely explored, and we felt that this was a way that we could define it most properly and use it as a term that we could use to include our studies. So it can be expressed using many different methods, such as performance arts like dance, music, singing, drama, theatre, or visual arts like painting, drawing, photography, sculpture, and arts. It can also be expressed through literature, writing, reading, poetry, as well as culture through museum, arts exhibitions, and galleries. So here is the inclusion and exclusion criteria that we used. So looking at our PICO framework, we looked at population, older adults aged 50 years and over, and that was really to get a wide inclusion of studies. And we excluded any study then that was less than 50 years of age, or where the mean age of the study population was 50 or under. In terms of the intervention, participants had to be actively engaging and participating in an arts and creativity intervention within a group setting and delivered under the guidance of a professional, and also the session had to be one or more. We excluded any study that looked solely at spectator or observational arts, which were performed solely for exercise purposes and without the guidance of a professional. We also excluded studies as a form of therapy for the treatment or amelioration of health conditions or disease. And that was really looking at narrowing the evidence base. We included any comparators that had a participation in routine care, usual activities, or whether there was an alternative comparator intervention. However, this was not a requirement. We then looked at outcomes that had objective and subjective measures of both physical and psychological health and wellbeing outcomes. And we excluded any study that had no clear health and wellbeing outcomes that were identified. In terms of study design, we included most studies. So we looked at both quantitative randomized control trials, before and after studies. And we also looked at qualitative and mixed method designs. The only study designs we did exclude was those who had single case report or individual case studies, commentaries, editorials, etc. So here you can see our PRISMA flow diagram. Records that we identified were 6,089, and we then identified an extra 12 as well through the Braille literature. And we in total ended up then with 73 studies that were included into the review, quantitative and mixed method as well, so there's 58 of those and 15 of the qualitative studies. So as I said, there are 73 studies were identified for inclusion. These studies were from over 18 separate countries with a cumulative sample of 7,263 participants, ranging from 50 years to 94 years. dance was the most common form of expressive arts creative exposure, and was reported in nearly half of the studies within the review in total. So there were 34 of those studies, and this was followed by music and singing, which 26 studies were included. Visual and creative arts then were 10 studies, and drama and theatre had 3 studies. These studies then went through a quality appraisal process. We used the mixed method appraisal to assess the methodological rigour, and all articles were included and not excluded based on low quality. Using those tools then, 13 studies were found to be high quality, 19 were moderate to high quality, 32 were moderate, and 9 were low quality. So what did these studies tell us then? The impact of arts and creativity and wellbeing. We used a system that was used by the What Works Wellbeing group, and we looked at the evidence as being strong, where we have confidence that it shows a positive impact on older adults. Promising, we have encouraging confidence that there's a positive impact and we need to explore further. Preliminary is where there is only a small indication of some impact, and we also need to explore this much further. And then we have inconsistent evidence, so the evidence was mixed and inconclusive to show an impact in older adults. And there was really, in some cases, there wasn't enough evidence to provide any commentary. So in terms of dance, there was relatively strong evidence suggesting that participation in group dance on a regular basis can enhance balance and mobility, lower body physical strength and flexibility, aerobic capacity and endurance, and it can increase time spent in physical activity. There was promising evidence suggesting that dance is associated with improvements in body weight, lipid and inflammatory profiles, cognition and brain function. There was preliminary evidence providing small indications that dance can help improve anxiety, independence in daily living activities, and reduce the fear of falling. And in relation to older adults living with diagnosed health conditions, we find some preliminary evidence suggesting that dance can help improve mood, depression, and cognition in older adults living with amnestic mild cognitive impairment. And it can also improve depression, self-esteem, and satisfaction with life in older adults living with age-related macular degeneration. There was also initial evidence indicated that tailored dance could help improve balance, mobility, and gait in older adults living with Parkinson's disease, but the evidence is inconsistent in this area and further research is required. In terms of the impact of music and singing, promising evidence suggests that participation in group singing and music classes on a regular basis is associated with improved cognitive function, quality of life, improve affective states, and can preserve a sense of well-being in older adults. There was some evidence suggesting the association between group singing and enhanced respiratory function. There was also some initial evidence to suggest that music and singing could help improve resilience and reduce loneliness. However, at present, the results were also inconsistent in this area, and more evidence is needed. In terms of high quality qualitative evidence from participants, it showed that participation in music and singing provided older adults with enhanced well-being, development of new skills, positive relations, and a sense of belonging and increased social networks. Visual and creative arts then showed that there was some preliminary evidence suggesting that visual and creative arts can help to reduce feelings of loneliness, improve a sense of community and social connectedness, and perceived health status and coping with pain experiences. There was high quality qualitative evidence suggesting that participation in visual and creative art group programs can help improve cognitive abilities, the acquisition of new skills, a sense of autonomy, enjoyment, and provides opportunity to develop new relationships and social connections. With regards to older adults living with diagnosed health conditions, promising evidence showed that visual and creative arts programs like creating watercolor paintings and art making can improve well-being in older adults living with dementia. And some initial preliminary evidence suggests that visual and creative arts programs can help improve activities of daily living and quality of life in older adults living with dementia. And lastly, the impact of theatre and drama. As there were only 3 studies in this area, there was only a small amount of evidence to suggest that participation in drama and theatre on a regular basis has been reported to provide emotional well-being benefits for older adults. However, as I said, the evidence on the impact of drama and theatre is quite limited and inconsistent, so there is so much more research that is warranted in this area. And what I wanted to do was just to show you the evidence within a table to get a sense really of what is there and also of the gaps that exist in the data. So at the top, you can see improved balance, mobility, strength, muscle strength and flexibility, cardiorespiratory fitness, physical activity, and you can see the strong evidence here. So 3 stars means strong. The 2 stars then is promising. The 1 star is preliminary, and the green star, as we said before, is inconsistent. And where there are no stars, it just shows you the gap that exists in the area. And that is in terms of the physical benefits. We also can see this again then for the psychological and mental health and well-being, particularly in dance, where there's a lot of inconsistent areas, but also the gaps in the research. So taking all this into account, we wanted to have a look at some considerations for research and evidence. What we identified then was there's further evidence needed on arts and health in a wider range of areas and across the different art forms to further develop the understanding of the evidence that we know so far for older adults. We also want to see more higher quality, larger scale and robust longitudinal research and experimental intervention studies so that we can track health outcomes for older adults to a much greater degree and increase scalability of these. We also need more standardized and systematic assessments of programs, and this would help advance meta-analysis and establish consistent treatment effects. And we also felt that a wider review of the economic evaluations of arts and creativity interventions was needed to determine the cost effectiveness and return on investment. And this would help support policy and decision making regarding the investments for future funding and commissioning of arts and health services. And Kieran and Grandia will discuss this later. So in terms of considerations for practice and policy, greater recognition of the public health benefits of participation within the arts and creativity should be promoted. We also see a number of barriers to be able to participate in arts and creativity, both social and economic, and these should be addressed to help improve availability and accessibility to the arts for older adults. We also feel a co-design approach. So by implementing a co-design approach with older adults and key stakeholders when designing and developing arts and creativity interventions would help to encourage participation and for a longer duration of time. Sustainability was a key thing as well. So looking at the sustainability of arts and creativity interventions and the sector to ensure more long-term investment is put in place. And those implementing arts and creativity interventions will benefit from making health and well-being a fundamental and overarching proportion and focus of their work. So being able to embed the structures in place to contribute to successful health outcomes. Further to this then, we felt that an evaluation framework is needed to ensure that it's integral to arts and creativity programs. And an evaluation toolkit is required to support those who wish to undertake an assessment of effectiveness, efficiency, and economic evaluations of arts and creativity programs. And that then would require training and support for the development and implementation of health interventions ensuring that they have effective program design and evaluation methods to inform and improve their services. A cross-sectoral and strategic working partnership is required to work through the arts and health and encourage progression of good practice and promote collaboration. For example, supporting collaborative working between primary care, social and community and art sectors. And finally, a strategic policy framework is required to help set the direction for participation and engagement in the arts, particularly for older adults within a health and wellbeing context. So just to summarise, to the original 4 questions that we had hoped to address in the research and the evidence. So how does participation and creativity impact on older people's health and wellbeing? Participation in arts and creativity has a positive impact on older adults' physical, psychological and social health and wellbeing outcomes. And what does the evidence tell us about whether they differ in effectiveness in supporting better health and outcomes? Well, the variability in the evidence hinders the ability to be able to conclusively determine whether certain arts and creativity-based activities differ in effectiveness than supporting others in better health outcomes, and more research is needed in this area. In terms of the evidence in the field as a way of collecting to measure and assess programme benefits and design, the evidence highlights various different objective and subjective ways to measure and assess programme benefits and design. However, a more standardised approach to these data collection and evaluation methods is required. And as you'll see in the report, we have identified some of those in there. What is the evidence that funding arts and creativity programmes for older people provides a return on investment? Based on the report that Roger and I have done, there was limited evidence that examines whether funding arts and creativity programmes for older adults provides a return on investment. However, the review indicated the dissatisfaction of short-term funding for the interventions and the need for a more sustainable and integrated public health approach. And as I said, Kieran and Grania will talk a bit more about the cost effectiveness and return on investment next. So the overarching messages from the review then is that arts and creativity interventions have positive health impacts for older adults and population health. Participation in group and arts and creativity interventions help to support the physical, mental and social aspects of ageing. And there are significant implications, especially for the promotion of positive health and for the prevention or mitigation of ill health in later life for both the public health and arts and creativity agenda. Thank you very much for taking the time to listen to our presentation, and I'm now going to hand over to Roger. Thank you.
Thank you very much, Laura. That was an excellent presentation, very clear. You covered all the main points. Just to make sure, let everybody know, the reports will be on our website, and there'll be a copy also of the presentations on our website after this event. Couple of housekeeping. There are, at the bottom of your screen, there's a Q&A. If you have any questions, please feel free to submit them. This is a chance for you to ask the different presenters some questions. If you would like to tweet, please do so, and please do engage with the presenters in terms of the things that you want to find out, because this is a great opportunity now in the next hour. Okay, so now we're going to move over to Kieran and Grania. The context for this is when Laura and I were undertaking this piece of research, we identified a knowledge gap in the area of arts and creativity interventions from an economic perspective. And so we were delighted to commission Clinical Costing Solutions, Dr. Grania Creeley and Professor Kieran O'Neill, to undertake a report that looked at the evidence from an economic perspective. And I'm delighted that Kieran is here today to make a presentation of what they found. So Kieran, thank you very much.
Thank you, Roger. And what I'm going to do is to share my screen and then take you through a presentation that I've prepared along with Gráinne Creeley. I'll be speaking to the slides, and then we'll be happy to take questions afterwards. Bear with me. So, okay. At times I'm going to lean into the camera, which might get a bit scary for you, so apologies for that. But hopefully it'll not be too frightening. So the title of our presentation is Arts and Creativity Interventions to Improve Health and Wellbeing in Older Adults, a review of the economic evidence. And in essence, what we were asked to do was to look at the methods that had been used to establish whether or not arts and creativity activities provided evidence of demonstrating value for money. So that can be phrased in a number of different ways. It can be phrased as cost effective. It can be phrased as a return on investment. A whole panoply of different phrases can be used to capture that. In the presentation, what I'm going to do is to provide you with some background. So why are we interested in this subject area? Why are we interested in how you would go about valuing arts and creativity activities as a use of funds? Then we'll look at the approach which we adopt, so the methods which we use to assess the current state of the methodology in this area. And because one of the things that we felt ourselves needing to do was not just look at what the methods were, but also about the challenges and limitations associated with those methods when it came time to actually apply them in practice. What we did was to look at the evidence which was currently out there as to whether or not arts and creativity activities, arts and creativity interventions did in actual fact offer value for money. So I'm going to take you through a literature review which we did of evidence in the area. And then what I'm going to do is to reflect on that evidence, so present the evidence to you and reflect on it to give you an idea of what we see as some of the issues, some of the challenges, some of the limitations associated with the different methods. And then come back in again at the end with some of the recommendations which we have as to how the science in this area, how the techniques in this area can in actual fact be moved forward. Now, I've been given until 11:35 to do that, and hopefully I'll not lose track of time. I am one to do that, but apologies if I do it in advance. So, again, what I'm going to do is to take you through my slides, but talk to them. So the background. So Suzanne and Laura have already given you some of the background in this, but I'm going to give you my perspective and that of Gráinne's in relation to this. We know we have an aging population. We know that our resources are scarce, and that's not just our healthcare resources, that's our resources in general. And we want to make best use of those resources to improve health and well-being among our older adults. And it's interesting whenever you start to refer to older adults and you see yourself actually being in that age group. So I'm part of the crowd now who are an older adult. And as Suzanne said, we can see this also in policy documents, whether it be Sláinte Care, whether it be Northern Ireland's documents in the area in relation to making life better, or indeed in the Bengal report, we see a move towards consideration of alternative ways of improving health and well-being that lie outside, strictly speaking, the health community. And we can see this also then in moves in respect of primary care, for example, around social prescribing. So while there is an awareness that a lot of these activities have the potential to improve health and well-being, there's a concern that whether or not public funds should actually be invested into them as a way of improving health and well-being. In other words, as a way of actually raising or improving healthy aging among our community. And part of the issues here are that you have activities which are going on across the board, which don't involve necessarily healthcare professionals, but you also have a range of spillover effects associated with them, and those present challenges. How do you actually incorporate those spillover effects, which may be benefits which accrue not just to the individual participating in the activities, but also benefits which accrue to wider society, including family members of the individuals who are engaging in this. So, as I said, we were tasked then with actually looking at the methods which had been made available. Now, at the risk of digressing too much, I want you to hold in your mind some background again to this. Health and care has a massive budget, as you know, and as you're aware of, and that budget is under pressure. And techniques have been developed over the course of more than 40 years to ensure that the scarce resources that are available for health and social care are in actual fact used to best effect. Now, those techniques have taken that length of time to actually develop. Those techniques have required significant effort in order to develop them, in order for them to evolve. And they've required a lot of to and fro between the different stakeholders in this to arrive at a consensus position. And that consensus position is largely captured in what are referred to as reference cases, which set out exactly how you can undertake an evaluation, a health technology assessment, a cost effectiveness analysis of a particular intervention. And part of the reason why that is the case is that significant amounts of money are being committed to these exercises, or to the interventions, to the decision whether or not to reimburse particular interventions. So it's understandable. Drug companies, medical devices companies, their future hinges upon their ability to convince people that their technologies are in actual fact worth investing in. That level of effort, that level of activity hasn't been manifest in some of these other areas of social value techniques. And that's something that we're going to see during the course of this presentation. So, as I said in my introductory remarks, one of the things that we deemed it important to do was not simply to look at what were the techniques which were available, but what were the challenges associated with applying those techniques in practice. So, in conducting this review of the methods to evaluate interventions in arts and creativity, activities in arts and creativity, we found it very important to actually look at the literature on the evidence. How had these methods been in actual fact deployed in the past? And that's what we then sought to do. So similar to the approach which Laura set out for you, we also then went on to look at the literature in the area. And to guide our search and assessment of the literature, we turned to what was considered best practice for the review, the systematic review of economic evaluations. And this is codified in a document which was produced by ISPOR, so that's the International Society for Pharmacoeconomics and Outcomes Research, so it's an international body. And over a number of years, working with a particular task group, and they produced guidelines as to how to go about reviewing the economic evaluation literature. So, and they've published those. So we followed the approach which was recommended in that, but we made amendments to it. And we felt it necessary to make some amendments to it in order to pick up literature which would not otherwise be captured were we to adhere slavishly to the ISPOR guidance. So look on the slide at the minute, you have a range of different documents there which underpin the pharmacoeconomic guidelines, and you can access those from the report should you be interested in identifying exactly what the methods were. But as I say, it follows a very similar course to that which was set out by Laura. So you set up your review team, you refine your study question, you develop a protocol which is going to cover things like search terms, and going to cover things like the search engines which you're going to use, etc. And then you go through that process.
Sorry, Kieran, just 1 second. If you don't mind, could you try and move closer to the laptop? I think we'll have some sound level issues where with your voice dropping in and out. So if you can come closer, then it might help that.
Okay, apologies. What I'll also do is to actually stop my video, which might be using up some of my bandwidth. So hopefully you can hear me, but again, cut in if it is the case that you can't in actual fact hear me. So hopefully you haven't missed too much of what I've been trying to say. But what I was saying was then, following a similar approach to that which was outlined by Laura, we undertook a review of the literature in the area, looking at the methods and how those had been applied and what they in actual fact found. So we set out the exact process that we were going to use in a protocol, which we registered with Prospero. And then we went through the different search engines with the different search terms, the different mesh terms, etc., in order to undertake that review. We extracted the data in a fashion similar to Laura set out for her review, her and Roger's review. And we also looked at the quality of the reviews, which had in actual fact been produced. My slides are sticking. Apologies for that. So you can see the process that we went through here on the slide as currently presented. So you'll see at the top of it, this is our Prisma flow diagram, similar to that which was shown to you by Laura. At the top of it, you'll see that we, in our analysis, looked at full economic evaluations and partial economic evaluations. Those are what we would consider to be worthy of inclusion, were we to stick slavishly to the ISPOR guidance. However, because we were aware of literature which would exist beyond full and partial economic evaluations, social value analyses as well, in other words, what we did was to allow for the inclusion of those into our search strategy. We concentrated on those who are considered to be older adults, so that is individuals in this analysis who are 50 and older. Our intervention were fairly eclectic, so we had a range of different interventions or activities. I'll use the term intervention and activity interchangeably. So we had a range of different activities which could in actual fact fall within the remit of this review. Those included performance art, creative and visual art, and creative writing, which also includes storytelling. And then we had a number of exclusion criteria, so criteria upon the basis of which we would exclude particular papers. So the intervention had to be participatory, similar to the review which was undertaken by Laura and by Roger. Individuals, in other words, would have to be engaging in whatever the arts and creativity activity was. And it would have to have as a possible outcome improvements in health or well-being, however those were actually specified and defined. It would have to be delivered by arts professionals rather than by clinicians or professions allied to medicine. It would have to be delivered in a group setting, and it would have to be delivered more than once. So on the basis of that Prisma flow diagram, we were able to sift through the various studies that we found. Something else which is important to note is that we look beyond what would be considered to be the academic literature, that is literature which finds its way into peer-reviewed journals. Again, similar to Laura and Roger, we looked into the grey literature, that is literature which would be published as reports, but not necessarily go through a peer review process. So we followed a pattern which would be similar to, which is familiar to some of you, I'm sure, the PICO acronym. So what was our patient group, if I can refer to them in that way? It was adults who were over 50 years, community dwelling or in a care environment. What was the intervention? Well, the intervention or activities here are, as identified in the previous slide, a whole range of different arts and creativity activities. What was the comparator? Again, unlike standard economic evaluations in a health technology assessment arena, what we allowed for here was the possibility that there would not be identified in an explicit comparator that could be compared against the intervention actually taking place. And that was to be mindful of the fact that not all of these studies would in actual fact have identified an explicit comparator. So while we looked for a comparator, we didn't require it to be the case that a comparator was in actual fact identified by the study. In relation to outcomes, we were agnostic as to what the outcomes could in actual fact be. So it could be that a study might have reported cost savings. It could be that it reported a ratio of benefits to cost, a return on investment. It could be that it would report a cost effectiveness analysis, such as a cost per quality, or a whole range of other benefits. So as I say, we were very agnostic. We were very general in terms of what the outcomes could in actual fact be here. What then did we find? Well, hopefully you can see all of what we found here in this flow diagram. So in looking at a period of publication between 2011 and 2020, across those various search engines, we identified almost 4,000 reports, 4,000 studies being reported in the literature or in the grey literature. And then whenever we applied those various sifting criteria that we had, so the removal of duplicates, because you might find the study in with one search engine or in another, whenever you remove or apply our exclusion criteria, we very quickly went down through those potentially 4,000 studies to arrive at just 6 in practice. So we found 6 studies, 4 from the studies, or 4 from the searches of databases, and 2 from the grey literature. More details on what those actual studies are shown there just to the left of the Prisma diagram, but I'm going to take you into them in any event. If I can get my slide to work. Apologies for this, my computer is sticking. Technology is a wonderful thing when it works. So it's going to be fun every time I change slides. So I was working like a tap dancer there. So hopefully you didn't hear too much banging on the keyboard. So what were the 6 studies? So the 6 studies were published between 2011 and 2020. 5 of those were in the UK and 1 of them was in the US. And these findings are informative in and of themselves. So one of the things which is informative in relation to them is just the small number of studies which have in actual fact been undertaken. If you were looking at drugs or medical devices, the number of studies which would have been published in that time would be, you could add a few zeros to the 6, let's put it that way. So there'd be an awful lot more activity in this area. There'd be an awful lot more scrutiny in this area of whether or not arts and creativity interventions offered value for money. That's not the case. Okay, there's relatively little evidence out there currently. What's also interesting is that the bulk of the studies were published in the UK and not the US. And that, I think, reflects back on the fact that the UK has a more socialized healthcare system and has a more developed infrastructure for the conduct of economic evaluations and social value analyses. So it's no accident, I think, that the bulk of the studies have in actual fact come from the UK rather than from other jurisdictions. What methods were used? 2 of the studies that we found were published, or sorry, used what we would consider to be traditional economic evaluation techniques, something that we would call a cost effectiveness analysis, in other words. 4 of them were social value analyses, that is to say that they were social return on investment analyses. In terms of where they published, the economic evaluations, the cost effectiveness analyses were published in the academic literature. The social return on investment analyses, 2 of them were in the academic literature and 2 of them were in the grey literature. In terms of the type of interventions that we found, 2 of them were singing interventions that I'm going to talk a bit about in a second. And 4 of them were art creativity interventions in a much more general sense. So they were more eclectic in terms of the activities which were in actual fact being undertaken. In terms of the target population, the individuals who were engaging in those art and creativity activities, 4 of them were for older adults with no obvious health impairment, no cognitive impairment. 1 of them was directed at participants with or without dementia, and 1 of them was directed at participants with dementia and their caregivers. And just the last point on that slide was that they were deployed across a range of different settings, both in the community, in care homes, and in both. Okay, so my slides seem to be moving a bit more smoothly. So if we look at the cost effectiveness analyses first, these were for the 2 singing interventions, Silver Song Club and Community Voices. That was the actual name of the studies which were identified here. Both of them we would consider to be high quality evaluations. And by high quality evaluations, we mean that they were underpinned by a robust randomized control trial. In other words, there was a comparator there was randomization there, and as a result of that, you could have some assurance that there was a reduction or a minimization of potential biases in the attribution of effects and costs to the intervention and control groups. Both of them adhered very closely to the reference case for the particular jurisdiction in which they were undertaken. So Silver Song was in the UK, and Community Voices, I think, was in the US. And in both instances, you have a reference case which guides the conduct of a cost effectiveness analysis. In other words, it's prescriptive and individuals are expected to adhere to it. And when reporting the cost effectiveness analysis, when reporting the assessment of value for money, and they in actual fact have to detail how they met all of the criteria set out in that reference case. So in a little bit more detail then, Community Voices. On the left-hand part of the slide, you'll see details as to what the activity was, what the intervention was. And on the right-hand part of the slide, you'll see details of what we had as the take-home message from this. Okay, so I'm not going to concentrate so much on what they did. If you're interested in that, the best thing to do is to actually go and read the original study, and you'll find details of that in the report which we've produced. But in terms of the take-home message, what they found was that the evidence of value for money, the evidence of cost effectiveness was equivocal. So they didn't find that the intervention here was cost effective. But we think part of the reason why that was the case is the way in which they went about assessing value for money. So what they did in this study was to look at quite hard primary outcome measures, which are more towards the clinical end of things, rather than some of the other outcomes that they could in actual fact look at, and that they do in actual fact report on in their study. So for example, there you'll see the example of chair stands, how many chair stands an individual is able to do. And the way these studies work is that you count how many they do in the intervention arm, how many they do in the control arm before and after the intervention to see whether or not you get a difference between the groups. While they didn't find differences in those, they did find them, as I say, in some of the other outcomes that they looked at. So loneliness and interest in life, some of the psychosocial outcomes, for example. That's important. And the second thing that is important to bear in mind in relation to this study is the perspective which they adopted when analyzing costs. So they adopted a payer perspective, a healthcare payer perspective. And in doing that, what you do is exclude the costs and potential savings which will accrue to other stakeholders to this activity. And it may well be the case that had they have included those, they would have seen savings that accrued to the individuals or to the individual's family members associated with them engaging in this activity. Now compare and contrast that with the next singing intervention, the Silver Song Club. Again, on the left-hand side of the screen, what you'll see is details of the actual activity of the intervention. And on the right-hand side of the screen, what you will see is the take-home message, the conclusions, as it were. And again, I want to draw out some of the conclusions and why they maybe got the conclusions that they got. So what they found was that the intervention was cost-effective. The Silver Song, the singing together group, was in actual fact cost-effective. And what does that mean, or how is that expressed? Well, it's expressed in the study as a 64% probability of the intervention being cost-effective, being value for money, in other words, at a threshold of £30,000 per QALY. Now, I appreciate that if you are not involved in this sort of discourse, if you're not involved in this sort of review, this sort of work on a day and daily basis, you might struggle to, in actual fact, understand what that meant. And what these authors did was actually to take that data and put it through a social value type prism and re-express it as a return on investment. So what you'll see at the bottom of the screen there is the cost effectiveness re-expressed as a return on investment. So they valued QALYs and in valuing the qualities, put a monetary value on the qualities, they were able then to relate costs to outcomes in monetary terms. And what you'll see there is that the return on investment was such that for every £1 invested, you would get around £44 returned in terms of benefits. One other thing to note in relation to this study is that they used a societal perspective when looking at costs, and they looked at a broad generic measure to generate quality. So they looked at the quality instrument that they used allowed for different domains of health to in actual fact be affected, different domains of quality of life, I should say, not health, different domains of quality of life to be affected. And that allowed them to pick up more aspects of an individual's life where they might experience benefits rather than something which is quite reductionist, such as chair stands. If we turn then to the social value analyses, as I say, we had 4 social return on investment studies, 2 of those in the academic literature, 2 of them in the grey literature. All of those evaluations were performed in accordance with current best practice, how that current best practice is in actual fact set out. And as I said in my introductory remarks, part of the issue here is that this method is one which continues to evolve. So it hasn't experienced the same investment by academics and others to codify, to make sure that it's rigorous and fit for purpose, as would be the case with cost effectiveness, cost utility analysis, etc. But these studies were done in a manner which would be considered to be in accordance with best practice, as I say, given what current best practice is actually understood to be. So whenever we assess the quality of these, there was no difference between the quality of the studies published in the grey literature compared to those in the academic literature, that which had been through peer review. All of them returned a positive SROI. That is, all of them suggested that you got more benefits back than was the outlay in terms of the investment. And in this slide, you can see the 4 interventions or 4 activities set out, and you can see an estimate of the SROI in each instance associated with them. So you can see that the return on investment ranges from about £1.20 per pound investment up to about £9.57 per pound invested. Now, it's incumbent upon us to actually put in a caveat here, and this is apologies for the Latin and for it's what we tend to use as part of our jargon in economics. Caveat emptor, and caveat emptor simply means buyer beware. And if what we're trying to do here is to signal the fact that because there's heterogeneity in the way in which these studies were conducted, because there are opportunities for individuals to include different things, to exclude different things, and to report particular costs in particular ways or not report them in particular ways, because there are, in other words, choices which have to be made because best practice has not as yet been codified with the same rigor as would be the case for health technology assessment. Someone who is considering whether or not to invest in these activities may have some degree of concern as to whether or not they are in actual fact buying something which is good value for money. So to go through some of the issues then, there wasn't an underlying experimental design to minimize bias. So none of these studies undertook a randomized controlled trial. So the evaluation wasn't associated with a randomized controlled trial, and the RCT is considered the gold standard way of minimizing the analysis of outcomes associated with an intervention. None of them had a comparator group. And again, this makes it difficult to assess whether or not something is value for money, because you always consider whether or not something is value for money relative to the other uses to which that money can be put. Now, that's not to say that they couldn't have done it, but in this instance, they didn't do it or didn't feel able to do it. And the last point then is just the technical standard applied differed by evaluators. So some of them in our assessment might have been more rigorous than others, more transparent than others. And that is something then which a funder would take into consideration in deciding whether or not to invest in these particular interventions, these particular activities. So where are we at? What can we say and what can't we say? So the evidence we can say is promising. So in all of the studies that we looked at, there is evidence to believe that they do offer value for money. So arts and creativity interventions offer value for money is our assessment, or at least there's evidence there to support that that is the case. But there are these caveats then that need to be borne in mind. So there's a small number of studies, only 6 that we in actual fact met our inclusion criteria. We're unable to make generalizations across conditions, disease areas, or socio-demographic groups because we have a small number of studies, and because of the design of those studies, it would be dangerous to generalize from them to other areas, to other types of activity, to other types of socioeconomic group who might be engaging in arts and creativity interventions activities. And where are we then in relation to the methods which are used to assess value for money? Well, both the reference case for public health and the methods underpinning SROIs, we feel have a way to go yet before they can provide a robust means of assessing whether or not interventions such as these offer good value for money. And then in our recommendations, we'll see what we think are some of the areas in which they could be improved. Now, presenter's prerogative, I'm not going to present these in the order in which they actually appear. So I'm going to come back up and talk about equity in a second. And I know that I've only got 2 minutes left, so forgive me if I rattle through them fairly quickly. So what would our recommendations be? If you are assessing value for money, use a broad perspective. In other words, look at societal costs rather than just a particular payer's cost, because you may well see savings elsewhere which accrue to other parties, and denying that those exist is a mistake. Outcomes can be captured in a variety of ways. You're not necessarily tied to using a quality outcome measure, but if you are going to use a quality outcome measure, use something which has a degree of spread to it, a degree of breadth to it, and which isn't going to be reductionist. Costs and benefits falling on non-health sectors should be detailed. In other words, what we're saying here is don't simply present a ratio of benefits to costs, but actually identify whose benefits and whose costs you're talking about in that ratio and the makeup of that ratio. All impact assessments should have a control group or a credible counterfactual, and that's the case for SROIs as well as those health technology assessments. You can, in actual fact, simulate what the impact of an intervention is relative to another intervention, even without a randomized controlled trial. And we would urge people to do that or consider how best to do that. Collect data post-implementation. Again, from our work in health economics, what we have seen is the introduction of an intervention and then the users of that change post-intervention. For those who are coming behind you, I think it's very useful to be able to demonstrate that not only did you consider it to be cost effective at a particular time or value for money at a particular time, but then gather the evidence afterwards to demonstrate that was the case. And then the last point before I go back up to equity, there should be a technical guide associated with an evaluation to set out with a high degree of transparency how the study was done, what the assumptions were that were made, if any, and where the figures came from. That'll help assure a funder of the quality of the work, of the rigor of the work. So I just want to go back up and take 1 minute to go over this equity issue. All of these techniques, cost effectiveness analysis, social return on investment, are explicitly associated with efficiency. And we think that they need to find a way to explicitly include equity into the valuation that they're actually looking at. So public health interventions of this type have a remit to actually address inequalities in health, disparities in health, and a way of incorporating that addressing inequities there needs to be a way of actually incorporating that into the valuation. And we have some ideas as to how that could in actual fact be done. So I'm going to stop sharing screens. Apologies if I went over by too much, and apologies for any breakup in sound as well. Roger, I'll hand it back to you.
Thanks, Kieran, for a great presentation, and Kieran Grania, thanks for a great report. Both our reports will be on our website. Now, just to remind people, if they have any questions, please feel free to submit them in Q&A. Now, I'm delighted to welcome Niels Picha, who's going to give a response. Niels, it's brilliant that you've taken time to do this, given the work that you've undertaken in the area of arts and creativity. So look forward to hearing from you now.
Thank you very much, Roger, and thank you to all the colleagues who've presented, who've done this fantastic work. To some extent, I'm kind of slightly lost for words, because I think it's just incredibly thorough and really takes the field by the scruff of the neck and kind of moves it forward. So first and foremost, I want to congratulate you for what's undoubtedly a great report that ticks a lot of boxes. And I say that coming from having off the back of having published our own report on the evidence base, which I think has rightly been criticized. As much as it's been lauded and promoted, has also been criticized for the fact that it was a scoping review that didn't go into the level of detail and didn't go into the level of kind of specificity as this report has gone. And obviously our intentions were different. Our intentions were to provide an overview of the field and to really kind of kickstart also WHO's own engagement with this topic. But that's not to say that these kinds of reports are incredibly important, and it's really wonderful to see the methodological rigor with which you've done your work. So that's really a kind of thing that I have to get off my chest in the very onset. One thing that kind of occurred to me as a response is I think the voice of the actual arts and health providers, the people who are doing the intervention, the challenges that they are facing is sometimes forgotten in this attempt to be scientifically rigorous, to provide best evidence, to show the health economic benefits, etc. And I do want to kind of take a moment to redress that, not to be apologetic, but just to kind of inject a little bit of sense of realism also into this conversation, so that we can hopefully move it even further along. And the first point that I want to make here is around the evidence of efficacy, the evidence of effectiveness. I think, Laura, you mentioned that in your presentation, and I fully agree with you that this is a fundamental importance. But there is this caveat, I guess, that you expressed, which is to say that there hasn't been a conclusive determination of effectiveness of arts and health interventions, or in this particular case, of these types of arts and health interventions. And while I think there's no way to disagree with that, I also think that there's a need to kind of contextualize this a little bit, and to think about what is actually possible. Is it in fact possible to conclusively determine whether an arts and health intervention, which operates in a complex field with complex intentions on very often complex health challenges, whether or not it is actually feasible, plausible to expect conclusive determination. And I say this because I think it's actually not a bar that we necessarily need in many other parts of the medical health ecosystem. I mean, I'm going to maybe make a slightly tongue-in-cheek parallel here, but in thinking about the COVID-19 pandemic, one of the public measures that has been highly promoted is the washing of your hands. And of course, that makes total sense. It's a very easy thing to do. It's relatively low risk, but the evidence on that specific intervention is never going to be conclusive. It's never going to be possible to conclusively prove that community spread is going to be significantly undermined by the washing of hands. It's just a bar that's incredibly high for a real world setting. And so I think, while I think it's important to continue being cognizant and aware of the need to improve and increase our evidence, I think we also have to be slightly realistic about what we can and cannot achieve. So the other couple of points I want to make are with regard to Kieran's presentation, because I think actually the question around health economics is really an important one. Certainly in my experience, as we're trying to move this field towards policymakers, towards implementation, one of the key potential arguments is to say, well, here's something, if you implement this, it's going to save you money, it's going to give you a return on investment. And this is incredibly difficult to do because, as Kieran has highlighted, not just in a specific area, but in arts and health more broadly, there's a real dearth of cost-benefit analyses and cost-effectiveness studies. And again, I kind of, this is not to be an apologist, but I think we have to understand that it is actually incredibly difficult for arts and health colleagues who are doing these interventions to tick all these boxes. A, because it's a difficult skill to have, but B, because it's also an added cost to the actual trial or intervention itself to include rigorous cost-benefit analyses as part of the study design. These things are costly, time-consuming, and difficult. And I say that from personal experience because we're in the process of developing an intervention in Romania and Denmark based on music and motherhood intervention for mothers with postnatal depression. And we're having very difficult conversations about what we can and cannot do with regard to cost-benefit analyses as part of our study design. So, and another challenge here, I think that's worth highlighting, and again, it's one that Kieran kind of alluded to, is that the framework for cost-benefit analyses is very much driven by the biomedical sector, by the pharmacoeconomic sector, and I think Kieran, the kind of ideas that you gave or the guidelines that you were kind of articulating about how those might be sensibly improved for the benefit of arts and health interventions, I think is really important. And in fact, it would lead me to a kind of conclusion that Laura mentioned that it would be useful to have a framework for measuring and evaluating interventions, the kind of a framework that can be used more generically across study designs and protocols, which is something I very much agree with. But I think the same could be said for cost effectiveness analyses. Having something that really caters a bit more to the specificities of arts and health interventions will be incredibly useful here. And again, I hope there's someone out there who can begin thinking about creating a framework like that. So I'm gonna end. I see that I'm kind of already out of time, but maybe just very briefly, I'm gonna end on one final note, and that's the question around what's next. The question around implementation. The report that you published gave some really good indications about high levels of high degrees of evidence with regard to dance and with regard to certain effects. And the question then becomes, what next? How do you integrate this into health systems? How do you implement this on the ground? How do you work with hospitals and hospital commission boards to try and actually figure out how to not only run them, but scale them, and then eventually benefit from the kind of greater attention, the research attention that necessarily is going or presumably is going to follow that kind of implementation exercise. So that would be my kind of big call would be I think the focus on evidence is always useful, but we also need to move this conversation on into the implementation phase. And in order to do that, I think questions around health economics are incredibly important. That's it for me. Thanks so much for inviting me to be part of this. I think I've learned a lot, and I look forward to hearing where your work goes.
Thank you very much for a great response, very thought-provoking, especially the issue of the importance of evidence, but the importance of moving to implementation. That's a really useful message. We've got some great questions. One of the questions is around barriers to participation in the arts by older people. Laura, do you want to touch on that? What you see are some of the barriers in terms of participation in the arts by older people, because we know that participation levels decrease as you get older?
Yeah, certainly. When we looked at the evidence in the literature, and when we look at continuous household surveys, what it was telling us was some of the barriers were cost, affordability of programs, being able to access venues, the awareness and the advertising of services as well, as limited times, and the access to transport were all barriers that were identified as I suppose, hindering older adults participation and access, and that's why we felt it was important that these barriers should be addressed.
Okay, Laura, thank you very much. Kieran and Grania, there's a few minor questions, and then we've got just a points of clarification. One question is, was this study conducted by a team of interdisciplinary researchers? And in the report, what does community dwelling care facility mean in the study? When you use those terms? Those are just 2 points of clarification. So Kieran and Grania, do you want to just
Grania,
answer
do you want to take
those?
those? You're on mute.
What I was going to say was, with respect to an interdisciplinary team, we were primarily health economists, but we had experience in undertaking systematic reviews previously, and obviously then we worked and collaborated with the Institute of Public Health, and we had information specialists involved as well with respect to the search and the search filters that we used.
That's great. And what about the second question, which is about community dwelling? It's just really a point of clarification.
Yes, we did not limit our search, so it was right across a variety of settings. So that included hospitals, community sector, care dwelling, and I see the specific question was about assisted living, so that was included as well.
Okay, there's great. In terms of one of the themes, Kieran, you touched on at the end of your presentation was around equity. Maybe yourself and Grania can explain how best can equity be addressed explicitly in evaluations. Now, this is your chance at goal, Kieran and Grania, to say what you think are the big steps and the small steps to get that to the fore, because when people get a chance to read the report, it's really striking. That's an issue that comes out very, very strongly.
If I maybe take a run at this first, Kieran, and then you follow. That's an excellent question, Roger, especially because it's a very difficult question to answer, because I don't think it's been fully resolved in the literature. With respect to the traditional types of full economic evaluation that we were talking about here, and as Neil said, it's related to the health outcomes, and in essence they're to do with efficiency or allocative efficiency. And so the outcome measures such as the quality adjusted life year, it doesn't matter to whom it accrues. So it could be someone who is in good health, somebody who's at the end of their life, at the end of their journey, or a hard to reach group. In the literature, there has been some work to look at weighting qualities so that it's reflective of when that quality is actually accrued. And there are other ways to address it through maybe subgroup analyses, but the case would usually be in a cost effectiveness analysis. The study would be powered to detect differences in costs and outcomes. And I guess another way to do it as well could be to explicitly undertake inequality impact assessments. And so there's 3 different measures that you could do, but at the minute, I suppose the health economics community, the jury is out as to which method should be used. Now, respect to the quality adjusted life year, what we're seeing now is for end of life care and for elderly people, the cost per QALY is being raised up to £50,000 per QALY rather than the standard 20 to 30,000. But as we move into an era of personalised medicine with some systemic therapies for cancer and the likes coming in at over £150,000 per annum, interventions such as this actually represent, relatively speaking, very good value for money, and they reach a wide proportion of the population. And I think that needs to be borne in mind when looking at these issues. And also, interventions such as this can reach a broad cross-section of the population and result in a large quality adjusted life year gain. And for those of you who are not familiar, it just means a year in good health. And so I think this is what we're trying to aim for with respect to healthy aging. Kieran, do you want to add to that perhaps?
Yeah, I think you summed it up well. So Roger, the experts in the area are going to continue to debate how best to do this, but policymakers are actually ahead of the experts in terms of the decisions which they make. So as Grania said, in the UK, for example, you had the Cancer Fund, which implicitly applied a higher threshold for cost per QALY to cancer patients relative to other types of patients. Grania's mentioned the orphan drug scenario as well, and the sort of rule of rescue, those who are near death. And again, those would have explicitly different thresholds associated with them. And things are getting a little bit more complicated. And I think it's probably because the drug companies are getting a little bit better about what they do. And so if you look at some of the drug approvals recently, and Grania mentioned the biologicals, for example, and the immunotherapy drugs and cancer, but also in relation to, for example, some of the cystic fibrosis drugs, they have much higher cost per QALY thresholds associated with them than what the jurisdictions introducing them into practice have set as the sort of the threshold that should be used. And what's more is that whenever the cost effectiveness study is done, that's not the end of the matter. Then it goes into a negotiation which goes on, or seems to go on, behind closed doors. And that really causes some anxieties for those of us who are working in the area about the whole equity question. How are QALYs for one group being measured against QALYs for another, for example? And in this particular area, which relates to older people, or largely to older people, the QALY as a measure itself would be inherently ageist, because the number of years over which gains can in actual fact accrue would be less than if it were an intervention targeted towards a younger person. So there are issues here to be threshed out. There are some methods which are being presented in the literature, but the professionals in this area, as it were, have not reached a consensus yet as to how best to incorporate equity into the analysis. It's very much on that basis currently.
Okay, Kieran, that's really helpful. But I suppose part of the conversation today is also to say, when undertaking these types of evaluations, we need to think about equity. We just need, not afterwards, but actually at the start of the process. Laura, it's back to you again. So Kieran and Grania, you can take a breather for a second. Now, couple of short questions, and why the age group 50 for this study, and then a slightly longer question. Could you just recap on the difference between therapy and therapeutic? I know you covered both in your presentation, but it's good to go over it again.
Okay, in terms of 50 years, we really wanted a quite broad generic age group. Globally, there is no specific age group, so some countries would use different criteria than others. So we felt, although 50 might seem quite low to some people, we felt that we could cover all participants within that. In terms of therapy and the therapeutic aspect, we defined therapy in terms of the treatment and management of both physical and psychological symptoms. such as health conditions or disease. We didn't want to replicate existing efforts in this area, so we excluded studies that were delivered by a therapist or a clinician, and also those that based in a hospital or clinical settings, engaging in clinical treatment or involving medical tests and surgery. And that meant then we could really open up the criteria in terms of arts to uncover any other forms, just really participants participating in arts and creativity activities. So therefore that health aspect was more well-being focused rather than clinical treatment.
Okay, thanks very much for clarifying that. Just a quick question. Should we take up dance rather than go to the gym?
So the review didn't compare dance with other physical activities directly. However, we know both dance and going to the gym are both good for our physical and mental health. The key thing is that we do things that we enjoy doing and that we love doing. But what we know from this review is that if you participate in group dance, you'll enjoy both physical and cognitive benefits.
Okay, thanks, Laura. It's now again time for you to have a rest from the questions. It's back to Kieran and Grania. In terms of, there's a number of questions coming in, so I'll maybe try grouping them. So one is, what needs to happen to provide a broader perspective when capturing costs and outcomes? Let me get the next one. Could evaluation frameworks encompass return on investments from arts delivery perspective as well as health and well-being? And if the outcomes sought are health-based rather than arts values, is it health sector's responsibility to fund this work? Okay, so there's three questions. We've only got a few minutes, so you can pick. They cover broadly the same areas. I'll go over them again. If the outcomes sought are health-based rather than arts values, is it the health sector's responsibility to fund such work? Could evaluation frameworks encompass return on investment from arts and delivery perspectives as well as health and well-being, which is a different question. And then the last question is, what needs to happen to provide a broader perspective when capturing costs and outcomes? So
again, if I maybe start and then Kieran, you spring in, I think that was sort of the message that was coming through from our review of the evidence, which is we need to have a perspective which is broader than just health, and that's what we were looking at. There is a fixation, well, it's not a fixation, it's just the methodology. The traditional full economic evaluations look at health-related outcomes. And what we know about public health interventions in particular is the spillover effects to families and carers and to society more generally. And so I think that's where the promise with the social return on investment analyses are. It's engagement with stakeholders. It's going beyond the usual health outcomes and looking at a much broader range of outcomes, deciding on what they are and how they're going to be valued. I think our conclusion was this is definitely worthy of advancement, but some of the technical work still needs to be done in terms of valuing these other spillover outcomes. Kieran, would you agree with that? And so betwixt and between, we have two different methodologies here and they need to come closer together. Either the full economic evaluations need to have a broader perspective, or the SROIs, the methodological improvements are required with respect to valuation of all these outcomes.
Thanks, Grania. I was very minded by one of the remarks that Neil's made in relation to this as well. And that is, and I meant to say this during the course of the presentation, that there needs to be more than tokenistic sort of engagements from those who are delivering the arts and creativity, and those who are, if I can describe it as participating in the arts and creativity. That dialogue between them and us as economists, I think, is important, and actually understanding what the outcomes are and how to measure those outcomes, because very often it is the case that unless it's counted, it doesn't count. So I think there's a meaningful dialogue there. And whenever, so some of the work that we do is an individual comes to you with an idea where they're going to pitch for funding, whether it be to a research body or whether it be to, for example, a public health agency or whatever for a particular activity. And what you would do in that situation is sit down and work with them in order to try and understand what the benefits are and who the beneficiaries are. And then from that, understand better how to, in actual fact, capture them and present them in such a way that they are going to influence the funder or the research community. So the Silver Song one, I thought, was actually very good in the way in which they went about this. So they used the QALYs, which is something that we would be typically familiar with, but then they put that through a prism of social return on investment to present a measure which could be understood more readily. And that would be the case for a lot of these sorts of interventions. If you'll forgive a second's indulgent, I'm always struck by something which was said to me whenever I was starting my career, and that was, how do you put a value on holding someone's hand in a hospital, just giving them that comfort? And it is, that brings you up short whenever your analyses come from books and only books, rather than in actual fact from talking to people and thinking about what the challenges to them are of understanding the value of the work that they do.
Good. Thank you very much. We're just nearly out of time, but Niels, I was going to ask you just give a final comment before I close on what do you feel is the overarching learning for public health going forward from what you've heard today?
Yeah, I mean, I think it's the point that I made about kind of moving towards implementation and recognizing that, you know, some of the flaws that keep coming up in these conversations about health economics, about you know, the lack of evaluative data, etc., are never going to be solved unless there's a kind of commitment to implement, to look at scale, and to try and see how these interventions operate, you know, in across a country setting, or at least across a part of a country setting. And I think, you know, I think it's too much to say that there's a leap of faith required. I don't actually think there's a leap of faith required anymore. There's been a huge amount of research that's gone into this, but we're not I think it would be misguided for us to look for perfect evidence. I think we need to look for evidence that is good enough, and I think that evidence is here, and I hope that the Institute of Public Health in Ireland and others who are from other countries can learn from that and also begin implementing on the back of the work that you've done.
Okay, that's a great summary. So thank you. What's really evident, you know, to me from this work and the interest in the event today is the need to help build a culture of sharing learning and evaluations, and not to be frightened of evaluations, but to ensure that we understand how to match individual needs with the most suitable programs. And we're very lucky because we've got 2 excellent reports that can help us develop an evaluation framework and toolkit. And that's our plan within the Institute of Public Health, because we really want to understand and support people to assess the effectiveness, the efficiency, and the economic aspect of arts and creativity interventions. And if this is of interest to you, please stay in contact and get in contact. I just want to finish off to say thank you very much. That we've had great presentations this morning. Thanks, Laura. Thanks, Kieran, and thanks, Grania, and thank Niels. This has been an excellent morning, and thank you all for taking part. All the best. Thank you.